Welcome everyone to this webinar of the All India Ophthalmological Society again. And this webinar is titled The Dynamics of Dry Eye Diagnosis and Management. And dry eye as such is a very difficult subject to understand. And through the various talks which are there, we will be taking you over the incidence of dry eye in India, the diagnosis of dry eye, the management of the dry eye. And we have international speaker with us, Professor Norihiko Yokoi. We welcome him to our webinar, and all the other speakers who are of international repute. I would now hand over to Dr. Srinivas Rao, who is the moderator for this webinar, for taking it forwards.
Thank you, Dr. Namrata. Welcome, everybody. Good evening. It's my great pleasure to introduce the speakers for this evening's program. The international speaker for this session is Professor Norihiko Yokoi. It was my pleasure to meet with him when I was in Japan last year at the AD's meeting. He is a clinical professor at the Kyoto Prefectural University of Medicine in Japan and is one of the founding members of the Asia Dry Eye Society, which, as you know, is based in Japan and works extensively on the ocular surface and dry eye. Today, he is going to be sharing with us a very interesting talk on his new method that he has proposed for the classification of the various types of dry eye that can impact the ocular surface. And it's of particular relevance to us, and we're very interested to be listening to him today because it uses only fluorescein and your slit lamp. So we don't need very expensive tools to follow this system of classification. And I'm really looking forward to his talk. We also have, as a co-moderator, Dr. Namrata Sharma, who needs no introduction. She's been extremely busy in the position of Secretary All India Ophthalmic Society, hosting various webinars. And I must say she's been doing a wonderful job. She's Professor of Ophthalmology in AIMS, but also holds important positions in the Asia Pacific Academy of Ophthalmology, the AIOS, the Eye Bank Association, and is in the ISCRIS as well. She has published extensively, and she is going to be speaking about the dry eye in Stevens-Johnson syndrome. Dr. Rajesh Sinha is our speaker who will be talking about the post-surgical dry eye. He is Professor of Ophthalmology at the AIMS. He is also associated with the ISCRIS and with the AIOS and was the immediate past secretary of the DOS. And as you know, he has also published extensively in various journals. And we'll be looking forward to his talk. Dr. Nikhil Gokhale is from Bombay, and I'm sure all of you know he has a keen and insightful mind. He basically asks questions that are very difficult to answer. He is the current president of the Cornea Society of India and was a past president of the Bombay Ophthalmologists Association. And he is extensively involved in the activities of the Cornea Society. He puts together the newsletter that we receive and has also published extensively. And his research interests are in corneal infections and ocular surface immunology and dry eye disease. And he will be speaking today on allergic problems of the ocular surface. Okay, Himanshu Matalia is the medical superintendent at the Narayan Nethralaya in Bangalore and heads the stem cell research group there and is a consultant in the cornea, ocular surface, and refractive surgery teams. He has a lot of clinical expertise in the problems that we will be speaking about, and so he is going to do the first talk for today, and he will be speaking about the current situation regarding the diagnosis of dry eye disease in India, the relevance of the news too, and he will be telling us what are the pitfalls that we are currently facing in India with all of these advanced technologies that we are supposed to be using to diagnose dry eye disease. So I'm looking forward to his talk. And I'm Dr. Srinivas Kera, and I will be co-moderating the session along with Dr. Namrata. So with this, let's start the program. I'll invite Dr. Himanshu to basically give his first talk, and then we will go on from there. We will probably be taking questions as they come. So maybe after about 3 talks, which is basically on the diagnosis of dry eye, we will take a break and address some of the questions that have come in. And then we will go on to the next set of 3 talks, which deal largely with the management of various problems. And then we can add some more questions after that as well. May I request Himanshu to do the first talk now, please? Thank you.
Thank you, Dr. Rao, and it's a pleasure to be here with such stalwarts of our field. Are my slides visible?
Yeah, perfect.
Yes.
Sorry. Okay. So I'm going to talk to you about dry eye diagnosis, and especially scenario related to our country and certain things, as Dr. Rao said, we'll critically evaluate these technologies, what we have at our hand. I do not have any financial disclosure here. Epidemiologically, we have seen the dry eye is certainly on rise, and it's increasing across the globe. And with the recent studies published about Indian prevalence, which is as high as 40% to as low as even 18%, which is a staggering amount of numbers of dry eye patients across in such a huge country. If you put together, it's an alarming amount which we are sitting on in our country, especially with regards to dry eye. So anything, whatever we do, we have to keep in mind whether the clinical implication of such kind of thing, whether possibility of such kind of thing to implement in a large country like us is possible or not. Due to give the latest definition of dry eye, which is, as we know, which is multifactorial disease. But in definition, there are certain factors which are very important, and I've highlighted them here as one of them is hyperosmolarity, second is apoptosis, third is inflammation, and fourth is TFM instability. These are the 4 main pillars of pathogenesis of dry eye. Whenever we want to treat any disease, if we know the pathogenesis, well, we can treat the disease more efficiently, because all we have to do is tackle these things individually, and you can actually treat the disease. So for the diagnosis purpose also, whenever we tackle the diagnosis, we will keep in mind that these are the things which we have to possibly address. Classification wise, whether it's due to or it's an Asia Cornea Society, ultimately we end up classifying dry eye into aqueous deficient, mixed, and evaporative dry eye. If it's an Asia Cornea Society, again, it's similar, like aqueous deficient dry eye, increased evaporation, and decreased wettability of dry eye. These things the next speaker would elaborate upon. The diagnostic approach wise used to told us that one we have a triage questions which involves many things like the discomfort and about the dry mouth, whether once the triage questions leads us to the dry patient, we start with the diagnostic test here, and I'm limiting myself to the diagnostic part here. So according to Deuce 2, apart from all the different questionnaires, 2 questionnaires which are more exhaustive and relevant was DEQ 5 questionnaire and OSDI questionnaire, where the score is more than 6 for DEQ and more than 13 for OSDI, which is significant. In the test part, they suggested we should have non-invasive tear film breakup time, osmolarity, and ocular surface staining. And we'll take these things one by one. The dry questionnaires are absolutely simple, and lately many of us have started using OSDI questionnaire. And I certainly feel that this is very relevant irrespective of whichever country we live in. Questionnaire does not cost you much, and we must start using questionnaire. The 2 things happen. One, it documents the subjective discomfort part of the patient and helps you to follow up the patient correctly. And third, it brings some uniformity in the diagnosis part or the documentation of the symptom part. So it's very important we stick to the questionnaire. Now, coming to the diagnostic tools, we have clinical diagnostic tools like fluorescein staining, rose Bengal, Lissaman green, tear film breakup time, Sherman's test, and so on and so forth. These are the commonest used across, especially in our country. And then we have device or instrument-based diagnostic tools like mevography, non-invasive breakup time, LIPIFLOW, LipiView, MMP9, osmolarity, many of these things. The next speakers, next couple of talks, they're going to talk about the clinical diagnostic parts. I'm not touching that part, but we'll restrict ourselves to these device or instrument-based diagnostic, and we'll critically evaluate them, whether it's worth in our country. So before we start that, again, we go back to the pathogenesis, and we are sticking to the pathogenic component of the dry eye, and one of them most important is hyperosmolarity. There are plenty of literature out there which shows the effect of hyperosmolarity on dry eye, and we know that higher the osmolarity, more will be the damage to the dry eye, to the ocular surface. But interestingly, if you look at the data, the variability or intertest variability of such kind of thing is very high. And if you look at the curve in normal versus dry eye, there's a huge crossover between that. That means you can have cases which are normal and you can have abnormal values of the test, or same way you can have a dry eye case but still can have a normal value. So looking at all these things, very high variability and very high expense involved of the machine as well as the consumable, it's a little difficult to implement in our country. Also, if we look at dry versus normal or mild to severe disease, there are publications which shows it can be same, the values can be similar. Whether it's Sjogren versus normal versus non-Sjogren, the values can be similar. Similarly, what if we diagnose and if we find that the hyperosmolarity is there, does it help us in treatment? Well, studies on hypoosmotic solution prove that even if you put in a hypoosmotic solution on the ocular surface, within a minute or two, the osmolarity level will come back to the before that level. So it does not help. So overall, if I look at the test, these are the questions I ask myself. That does it help me in diagnosis? This certainly does not. Does it help me to decide about the severity of disease? Well, can't say that, because we saw that even severe disease can have a normal value. Does it help in treatment? Not exactly, even though it tells me that a higher osmolarity is severe dry eye. Does it have good repeatability? No. Does it have good sensitivity, specificity? No. Does it have good value for money? No. So in that case, possibly this is not the test which I would like to use. So even though Deuce 2 tells us to use osmolarity as one of the very important feature, I don't think it's very relevant in our country to use this thing. Coming to the next part, inflammation part. The inflammation and dry eye has been studied a lot, and we know that it's sort of a white inflammation. It may not show the congestion. There is one test for the MMP9 level, which is commercially available in our country. Though it's not very easy to procure it, but it's certainly not not reachable to most of us. It's a very simple test, and when we do the test, it tells us if the MMP9 level is more than 40 nanogram per ml. If the MMP9 level is high, that means it's a significant inflammation on the ocular surface, and patient would need anti-inflammatory molecules like cyclosporin, topical steroid, or tacrolimus. Or if the MMP9 level is less, then possibly the lubricants may be good enough. If we again look at the same questions which we earlier saw, well, does it help in diagnosis? Equivocal. I can't say that very significantly. Does it help in decide about severity of disease? Again, very equivocal. About the treatment and everything, value for money, it looks like it's more of equivocal. So it's a low priority. If you have it, you certainly can use it, but I don't think I would stress upon this thing as my mainstay of treatment. Coming to the next part, which is TFM instability part, and which is a very important chunk of dry eye which we deal with, and that's the evaporative part of the dry eye. There are a lot of improvement in the treatment here, especially thermal pulsation and like LIPIFLOW and iLux device, and many such devices are there in the market, which helps us to treat these MGD more efficiently now. But when we come to diagnosis, there's one important diagnostic test which I would like to mention here is meibography. In the meibography, we image the meibomian glands of upper lid and lower lid. And as you can see from the picture here, we can see these vertical comb-shaped distribution of meibomian glands in normal case. And on the right side, you see significant loss of meibomian glands in abnormal cases. Why is it important? Well, we know that in case of MGD, the mainstay of treatment has to be warm compresses, lid massage, or the treatment protocols like LIPIFLOW or iLux and such kind of newer treatment devices. But what if we do a meibography and find that meibomian glands are normal? Well, this is going to be fine. But if the meibomian glands are not normal, if they are absent, whatever we do like this kind of thing, it's not going to work. So it's extremely important whenever we are utilizing such higher end devices to treat MGD to confirm if there is significant loss of meibomian glands, and hence there cannot be any lesser role of meibography in such kind of cases. So meibography, according to me, is must. Now, what in our country, meibomian gland imaging is difficult. Well, I have been doing meibography for a very long time before even the machines were available on my autorefractometer. So any device which emits suitable infrared range, you can actually use it to image your meibomian glands. So I don't think we can claim that availability of meibographer can be an issue. However, if we look at the again same questionnaire, it actually ticks all the boxes. It helps us in diagnosis, it helps us in severity of disease, it's repeatable, it's very good sensitivity, specificity, and certainly value for money. And I would certainly say that a meibography is must in our country when we are treating the dry eye. There are certain devices which are a comprehensive dry eye diagnostic devices, like one of them is Keratograph 5M. Another is Ocular Surface Analyzer, and there are a few other also there in the market, and they can work beautifully well in the clinics. Keratographer can do topography and also can do meibography, non-invasive TFM breakup time. It can do interferometry and lipid layer analysis, the tear meniscus measurement, pupillometry, white to white measurement, redness score, and it can take diffuse picture also. Ocular Surface Analyzer, along with this thing, does not have a topographer, but can be quite mobile and handheld, and can help you with the blepharitis assessment also. So such kind of devices can bring certainly huge amount of value to our diagnosis. Another dry eye diagnosis related to the tear film instability is LIPIFLOW, which is interferometry-based analysis of lipid layer, and which also tells us about the lid dynamics and blinking dynamics. It's certainly a very beautiful machine and gives you very nice interpretation of lipid layer. But if you look at the limitation, it has poor repeatability, poor correlation with sign symptom, does not guide us about the treatment or need of treatment. More of a costly machine to study blinking pattern. So if we again go through the same list, does it help us in diagnosis? No. Does it help to decide about severity? No. Does it help in treatment? Of course not. Good repeatability? No. Value for money? No. So I don't think I would be very keen on investing on this thing. So what are challenges when we come to our country? In busy OPDs, all of us, we find same thing, that time-consuming test, many time things which we have to do, we do not have time to do, or we may not have a reliability of usage of that test. There are a lot of overlaps between normal, abnormal, and also the diagnosis of dry eye has become more instrument dependent, and lack of correlation between sign and symptom. So according to me, the dry eye diagnostic in our country, the gold standard should be symptom questionnaire, ocular surface staining, tear film breakup time, Schirmer's test, and meibography. Finally, I close with these questions: that can dry eye diagnosis be further simplified than keeping it more elite and keeping it for more specialized people only? Because this problem is much more pronounced than what we think. Do we need simpler method of assessing dry eye? Because getting more and more instrument, we are getting more and more dependent on instrument. Are there ways which we can use a simple technique or few simple techniques in our outpatient to possibly detect the dry eye more efficiently? With this thing, I would conclude, and my future speakers would take up the cue from here. Thank you very much.
Thank you very much, Himanshu, for that beautiful talk, which, like a management algorithm, simplified everything. It is my pleasure now to invite the next speaker, and that is Professor Norihiko Yokoi, and he's going to be talking to us about dry eye diagnosis from the lens of Asia Dry Eye Society, ADIS. So I think it's going to be again another very illustrative talk. So over to you, Professor Yokoi.
Sorry. Can you see my slide? No?
Not yet.
Sorry. Can you see my slide?
Yes, we can see the slide. Perfect.
Okay, thank you. Thank you, Dr. Rao and Dr. Sharma. Moderators. Good evening, everybody. It is my great pleasure to have an opportunity to here at this web symposium. First, I would like to thank Dr. Rao and Dr. Sharma and Santen India for their kind invitation. Today, I will talk about dry eye diagnosis from the lens of the Asia Dry Eye Society, while introducing T-POT tear film oriented diagnosis for dry eye based on fluorescent dynamics. I will also introduce decreased wettability dry eye, the new important concept in tear film oriented diagnosis. Based on T-POT, 30 seconds are enough to suggest the insufficient component for the ocular surface and to classify the dry eye subtype for dry eye. This slide shows my disclosure of COI. This slide illustrates the difference of corneal surface between normal eye and cases of dry eye. As seen in those movies, in normal eyes, the tear film is stable and is not easily broken up, even when the eye is kept open. In contrast, in cases of dry eye, the tear film is unstable and easily breaks up with resultant epithelial damage. The visible abnormality of unstable tear film reflecting in the fluorescent breakup and epithelial damage is helpful and essential to the diagnosis of dry eye. Ideas about the mechanisms of the vicious cycle of dry eye vary between Japan and the United States and elsewhere. In Japan, we pay more attention to unstable tear film when considering the vicious cycle. From this aspect, any tear abnormalities or decreased wettability of epithelium will cause unstable tear film, which result in epithelial damage. And the resultant epithelial damage will cause unstable tear film via the decreased wettability of the epithelium, thus resulting in the vicious cycle. In the United States and elsewhere, hyperosmolarity and inflammation, resultant inflammation are thought to be included in the vicious cycle, and more attention is paid to the inflammation. Those differing ideas often influence the emphasized findings in the diagnosis and therapy for dry eye. In Japan, we emphasize the visual abnormalities, including breakup time BUT and superficial punctate keratopathy, or SPK. In contrast, in the United States and elsewhere, invisible abnormalities, including hyperosmolarity and inflammation, respectively, are emphasized in relation to diagnosis and therapy. We Japanese dry eye specialists do not deny the importance of inflammation, but in general, we regard inflammation as the result of the vicious cycle and not the cause of the vicious cycle. This slide shows the definition of dry eye from T-Post 2. According to this definition, dry eye is characterized by a loss of homeostasis of the tear film, in which not only tear film instability, but also hyperosmolarity, inflammation, and damage and neurosensory abnormalities are important etiologically. On the contrary, the Asia Dry Eye Society held a diagnostic definition and dry eye collaborative investigation meeting in 2014. We proposed here our definition of dry eye from the Asia Dry Eye Society to define more precisely the dry eye cases that we encounter clinically. In this definition, dry eye is defined as a multifactorial disease characterized by unstable tear film, causing a variety of symptoms potentially accompanied by ocular surface damage. We emphasize here the importance of unstable tear film as a visible core manifestation of dry eye. The reason why unstable tear film is so important, there is a short BUT type dry eye, which is sometimes overlooked but needs treatment. The representative cases of short BUT type dry eye shown in those movies. You can see minimal or no involvement of corneal epithelial damage in spite of very shorter breakup time. An original and insightful report about this dry eye subtype was reported by Professor Tsubota's group, where short BUT type dry eye was introduced as dry eye seen in younger age patients with severe symptoms such as dryness and eye fatigue, with abnormal BUT yet no abnormality in CMR1 test and clearance test, and with association with allergic conjunctivitis. Recently, there are increasing number of studies on short BUT type dry eye, in which an association with visual disturbance, the effective treatment by eye drops or punctal plugs, and the relation to decreased mucins have been reported. Together with our definition of dry eye, we proposed our diagnosis of dry eye from the Asia Dry Eye Society to more appropriately diagnose the dry eye cases that we encounter clinically. In the diagnosis, we emphasized again the importance of unstable tear film as a visible core manifestation of dry eye. Based on this definition, we have established the diagnostic criteria for dry eye in Japan in 2016. In this 2016 criteria, the definition became very simple and it involves only the positive symptoms that are related to ocular discomfort and or visual disturbance and an abnormal BUT of less than or equal to 5 seconds. In this diagnostic criteria, the short BU type dry eye is diagnosed as definite dry eye and should be treated. However, it is important to note that abnormal BUT tells nothing about dry eye subtype, thus resulting in an inability to consider the most effective treatment for each dry eye case. Please watch this movie. Associated with this, can you tell what is the insufficient component associated with this dry eye? What types of dry eye? The answer is provided TPOT by TPOT tear film oriented diagnosis. In order to discover any insufficient components of the ocular surface responsible for tear film breakup and classify the specific dry eye subtype, it is quite useful to observe the dynamic behavior of fluorescein and fluorescein breakup patterns. One of the most important properties of tear film is stability. The four components that support tear film stability are the tear film lipid layer that is thought to suppress evaporation of aqueous tears from the aqueous layer, aqueous tears of the tear film, in which sufficient aqueous tear volume is important for supporting tear film stability. Secretary mucin, Mach5AC of tear film, which gives gel character to the aqueous layer, and membrane-associated mucins, especially the longest Mach16, which retain wettability of the corneal surface epithelium. With abnormalities 1, 2, 3, and or 4, the tear film becomes unstable, that resulting in tear film breakup that leads to epithelial damage. TPOT, tear film oriented diagnosis, to find the components responsible for tear film breakup from 1 to 4 has advanced in Japan. Tear film oriented diagnosis, or TPOT, is a new world direction originating from Japan. TPOT is a diagnostic method to suggest the insufficient component of the ocular surface responsible for tear film breakup and the specific dry eye subtype. For TPOT, observation of tear film dynamics and the classification of the tear film breakup pattern are essential. For example, this breakup pattern is a line break, which suggests that the insufficient component is aqueous tears, and the specific dry eye subtype is an aqueous tear deficient dry eye. Therefore, the point of emphasis for evaluating dry eye in Japan has shifted from epithelial damage, BUT, to TPOT via breakup patterns. This scheme produced by the Dry Eye Society of Japan shows the detailed concept of tear film oriented therapy, TPOT, illustrating the target for therapy and the possible candidates for topical therapy currently available in Japan and elsewhere to improve tear film stability. In this concept, detection of the insufficient components of the ocular surface responsible for tear film breakup is the first step, which is followed by the supplementation of insufficient components to attenuate dry eye symptoms via the prevention of tear film breakup. However, for the detection of the insufficient components of the ocular surface responsible for tear film breakup, TPOT, tear film oriented diagnosis is essential. And for TPOT, classification of breakup patterns is the most effective and useful. Here, I'd like to introduce the fundamental knowledge about the wettability of the surface. Please have a look at this photo, and note the water droplet on the petals. When the petals are tilted, it is expected that the water droplet will easily fall off. So like petals, stability of the aqueous fluid is not only determined by the specific fluid components, but also by the wettability of the surface. It is well known that the condition of the contact of aqueous fluid to the surface is determined by the wettability of the surface. In other words, wettability, and that when the wettability, in other words, hydrophilicity and water holding property of the surface is better, the aqueous fluid is more stable. In regard to water repellency of the surface, this relationship is reversed. On the surface of the cornea, wettability is thought to be maintained by the intactness of Mach 16, the longest of the membrane-associated mucins. Please watch this movie. This is an example of decreased wettability dry eye, in which you can see a spot break at the upper part of the cornea immediately after eye opening, and random break with rapid expansion at the inferior part of the cornea. At the lower part of the cornea, after the tear film established on the cornea, which is confirmed by the stoppage of upward movement of fluorescein, once random break happens in the inferior cornea, it expands very rapidly due to the decreased wettability of the corneal surface. Spot and random break with rapid expansion both correspond to the breakup patterns seen in decreased wettability dry eye. We should pay more attention to decreased wettability dry eye, which can be diagnosed through T-pod based on breakup patterns. This slide shows the dynamic behavior of each tear film layer until the establishment of the tear film theoretically. This is a cross section, this is the upper lid, and this is lower lid. During eye opening, capillary suction pressure from the upper tear meniscus pulls the aqueous tears up, resulting in the deposition of aqueous tears on the cornea. However, insufficient suction to pull the lipid layer up results in the surface pressure gradient on the lipid layer immediately after eye opening. This gradient, in turn, results in an upward split of the lipid layer, which simultaneously drags aqueous tears up. However, simultaneously with the aqueous drag, there is an aqueous thinning by the capillary suction pressure of the lower tear meniscus. In those movies obtained from the same eye, tear film lipid layer behavior, together with fluorescent stained aqueous movement can be seen. After the cessation of the upward split of the tear film lipid layer or upward movement of the aqueous tear film, precorneal tear film is established. Related to this tear film establishment, 5 different essential tear film breakup patterns can be classified. The first is the area break. When the aqueous tear's volume is extremely diminished, you can't see any upward movement of fluorescein after eye is opened. The second is the spot break, when the wettability of corneal surface is impaired. You can see the spot break immediately after eye opening. The third is the line break, resulting from the simultaneous action as explained, aqueous drag and suction from the lower tear meniscus, which result in the line-like breakup during the upward movement of fluorescein. The fourth is the dimple break, which is speculated to be related to the decreased wettability of the corneal surface. You can see the dimple break during the upward movement of fluorescein at the thicker part of aqueous layer. It is quite in contrast with the line break. The fifth is the random break, which thought to be related to increased evaporation. After the stoppage of fluorescent movement, upward movement of fluorescent, after the establishment of complete tear film, you can see the breakup. This is the evaporative mechanism. This is the summary of the classification of fluorescent breakup patterns. Fluorescent breakup patterns can be classified into 5 patterns, which include area, spot, line, dimple, and random breaks. These are essential breakup patterns that occur in dry eye based on different mechanisms. In addition, rapid expansion of the breakup joined in this essential breakup patterns, and here you can see a case of line break with rapid expansion. Based on the breakup patterns, we can suggest insufficient components of the ocular surface. For area break, aqueous fluid is insufficient. For line break, aqueous fluid. Spot break, dimple break, rapid expansion. Mach 16 is insufficient. And random break lipids or Mach 5 acid, which can suppress the water evaporation, is impaired. Also, based on the breakup patterns, we can suggest the specific dry eye subtypes. Area break corresponds to severe aqueous tear deficient dry eye. Line break corresponds to mild to moderate aqueous tear deficient dry eye. Random break corresponds to increased evaporation dry eye, and the spot, dimple, and rapid expansion of the breakup are thought to correspond to decreased wettability dry eye. Here, I would like to introduce a very important steps of how to effectively perform T-pod via fluorescent breakup patterns. First, in order to not to increase tear volume, a less invasive way for staining tears is essential. Installation of 2 drops of saline and artificial tears followed by vigorous shaking of the stained strip, and just touching the central top of the strip to the lower lid margin. I showed you here 3 times, but once is enough to stain the aqueous tears by fluorescent. Second, after several blinks, the patient is verbally instructed to briskly opening the eye and keep the eye open after gently close the eye 3 times to confirm the reproducibility of the breakup pattern. Gentle close, rapid eye opening is important. You can't see any breakup patterns during the natural blinking. And you can confirm the rapid expansion of break. This is a line break with rapid expansion. Please note, a reproduced breakup pattern must be more related to the pathophysiology. The first case is corresponds to the spot break, and the second case corresponds to the line break with rapid expansion. Via T-pod both correspond to decreased wettability dry eye. This slide shows the classification of dry eye disease proposed by T-pod due to. Please note that for the classification of dry eye, T-pod due to proposed only 2 dry eye types, subtypes including aqueous deficient and evaporative, although there is a mixed type of those. On the contrary, this slide shows a new dry eye disease classification proposed by the Asia Dry Eye Society, in which decreased wettability dry eye is included as an important and neglectable dry eye subtype. As another breakup pattern for decreased wettability dry eye, we recently added a breakup pattern with rapid expansion. And the corresponding main breakup patterns for each dry eye subtype are indicated here. In summary, the most important property of tear film is its stability, and the fluorescent breakup can be a visible core manifestation of dry eye. T-pod, tear film oriented diagnosis, is a new concept for dry eye diagnosis based on the observation of the tear film dynamics and the breakup patterns using fluorescent. This can provide information about the insufficient component of the ocular surface to make tear film stable. And that's a dry eye subtype. From the point of T-pod for dry eye, not only the detection of spot and or dimple breaks, but also the detection of rapid expansion of breakup must be essential for a proper diagnosis of decreased wettability of corneal surface and or decreased wettability dry eye. Recently, I published a book entitled Teapot and Teapot Expert Lecture, Paradigm Shift in the Clinical Practice for Dry Eye. An English version of this book is also available. You can enjoy Teapot and Teapot quizzes on your mobile device. I hope that you will be able to master Teapot and Teapot through reading this book. Thank you very much for your kind attention.
Thank you so much, Professor Yokoi. I think it's a great contribution to the ocular surface and to cornea. The discovery of TFOD or the existence of TFOD, it makes a lot more sense. I think maybe all of us have not paid attention to it, but it's a great tool to have, and it's a great way to look at the tear film dynamics. I'm sure it is going to be useful for everyone. Before we take the questions, I would now invite Dr. Srinivas Rao, my co-moderator, to give his talk on the dynamics of the dry eye disease. And by dynamics, it again means the tear film staining. And this is one of the best lectures I have, heard on it. And I'm sure we are again going to have a great scientific feast on this, and it is extremely practical and useful.
Thank you, Dr. Namrata. We just heard an excellent presentation by Dr. Yokoi, talking about a new way of looking at fluorescein staining. I'm going to talk about the more traditional concepts that we have been using regarding fluorescein staining and some of its nuances. When you're looking at any subject or problem, one of the ways that has been described to understand it better is to ask these questions, which are described as the 5 W's and the 2 H's. We can use this concept when we are looking at the assessment of the ocular surface health using stains, and that is what I will be talking about, the dynamics. If we look at the first question, which is the why, we have to ask ourselves, why do we need to stain the ocular surface? We just heard about the use of fluorescein staining, the negative part of it, from Professor Yokoi. So we use the fluorescein, and based on where it does not stain, we try and understand the impact on the ocular surface. I'm going to be talking about the positive fluorescein staining. So what do we do when we actually see fluorescein staining the ocular surface, and how do we assess its impact? So the reasons for staining would be to detect the presence of ocular surface changes, use these changes that we detect to diagnose different types of ocular surface disease, document its extent, and use this documentation to help prognosticate the disease when we talk to the patient. And after we start treatment, follow up the surface to see whether it's getting better or worse using these very same changes. Who are the major players as far as this sequence is concerned? All of us are familiar with these 3 stains that we use. The most recent entrant is Lissamine green in 1973. And no talk on ocular surface staining would be complete without mentioning the work of Non, who worked extensively studying the interaction of all of these 3 dyes with the ocular surface and published a series of articles from 62 to 85. So we understand that we can use fluorescein for the cornea, and we have traditionally used rose Bengal and Lissamine for the conjunctiva. Although rose Bengal was the first entrant, recently, because of its irritating properties, its cellular toxicity, and the reason why that it photosensitizes the cells, there has been a trend to move away from it and more towards Lissamine green, which has all of the good properties of rose Bengal without the side effects. Also, when you're looking at staining of the conjunctiva on an angry red background, the green stain shows up better than the red stain itself. All of these dyes can be used as strips or solutions, and the concentrations are given here. The solutions are generally better because we can put graded amounts, predictability on the ocular surface. But if you're going to use it in the clinic, make sure that you have the minims, which at the moment we don't in India, because if you keep a bottle of these, it gets contaminated very easily with Pseudomonas, and we all know what can happen after that. So what is it that we actually are seeing when we put these dyes on the surface? So what I've done is basically I've shown you the epithelial surface, I've shown you the epithelium in cross-section, and this is an ultrastructural study. The reason why the normal surface does not stain is because of these healthy epithelial cells on the surface. The fact that they are bound to each other by tight junctions, which are impervious to anything but the smallest molecular weight solutes. And the surface contains microvilli, which absorbs the mucin, the membrane associated mucins, and together they form the glycocalyx. And when these three are present, the stain does not take up on the surface. If for some reason there is damage and the stain gets through to the deeper layers of the corneal epithelium, there are gap junctions between these deeper corneal epithelial cells, and the dye can then diffuse. So the epithelium of the cornea is a semi-permeable layer for fluids and only for the smallest molecular weight solutes. So when we actually see staining, we use the term superficial punctate keratitis. What happens here is that there can be a loss of the tight junctions between the epithelium, a loss of the glycocalyx, or individual cell death. And this results in this fine stippling that we see because of the surface events that are happening on the corneal epithelium. The next step after this is what we call punctate epithelial erosions. It is just the same pathology, but of an increasing degree. There is more cell death and more layers of the six-layered corneal epithelium are lost. So you get little craters where there can be pooling of the dye, and this results in the coarser pattern of staining that we see. We can also see this coarser pattern of staining when there is epithelial multiplication and heaping, which we typically see in adenoviral or microsporidial keratitis. And here, the way to distinguish it would be to make a slit. And in this, because of the elevation, this plot of staining would be an elevated convex structure, whereas in the previous instance, it would be a depressed concave structure. Of course, after this, if the disease progresses, there is a loss of all the cell layers of the corneal epithelium, and then you get a total epithelial defect. So here it's not just the area of the epithelium, but the fact that all layers are lost, which is typical of this. And whenever you see a defect, we also want to pay attention to the surrounding epithelium. You can see the breakup here. You can see the shattered light reflex of the slit lamp light here, all of which indicates that this is an unhealthy epithelium. And if you look at the margins of the defect, they are convex outwards, meaning that there is no attempt at healing. The edges are heaped up. So this is a typical non-healing or a persistent epithelial defect. So when do we use these dyes? Basically, you do this to look at ocular surface health loss when you have a dryness and there is damage to the cells. You can use it to stain the tear meniscus to measure its height more better. You can use it in a fluorescein clearance test to look at the evacuation of the excretion of the dye from the surface. You can use it in limbal burns from alkalis and so on. So you can look at the limbal stem cell damage, and you can use it on the corneal surface to look at the various infections that we see. We can also use it to look at leaks, either from blebs or from corneal injuries. From the assessing the effect of contact lens use on the cornea, you can see the 3 and 9 o'clock staining here. And in LASIK, if you see an epithelial ingrowth and when you stain the surface, if you see a spot of staining here at the edge of the flap, it means that the cells inside in the interface have a communication with the outside, and this is an indication for surgical removal of this ingrowth. Again, in LASIK, if you see this pattern of positive and negative staining, this indicates LASIK flap folds, which are full thickness events, and this helps you differentiate them from striae in the flap, which are within the substance of the flap, wherein you will not see this positive and negative staining. You can also use these dyes to stain the surface of ocular surface tumors. How much of this dye do we use? Again, Professor Yokoi mentioned it. For fluorescein, we want a very small amount of 1 to 2 microliters. You can be more generous with the other two and use about 25 to 30 microliters. I'll explain why in the next slide. It's also important to pay attention to the diluent. Ideally, it should be normal saline, which often is not available in your clinic. But what you should not use is a tear substitute which contains CMC, because that acts like the mucin, coats the surface of the cell, and subtle findings can be lost. Where do we put it? For fluorescein, we typically put it in the lower palpebral conch, like we just saw. But if you have a dry eye, and if you're using a lissamine and rose bengal, or one of the two, and if you think there's not enough tears to take it across the surface, another way is to take it on the strip and then put it in the superior bulbar conjunctiva. So gravity will help it spread over the entire surface, and you can get better staining characteristics. A minor but important issue is that all of these dyes can stain the periocular tissues, and therefore you want to be careful, otherwise the patient may not be happy. So if we look at fluorescein, if you have very little fluorescein in the tear film, you don't get adequate fluorescence. As the concentration increases, so does the fluorescence. But paradoxically, when you exceed a certain amount of concentration, the fluorescence again decreases, and this is the phenomenon of quenching. So the sweet spot for maximum fluorescence is when you have this mid-range, neither too little, not too much. And that sweet spot is when you have a 0.1 to 0.2% for ideal fluorescence. And that is why you want to use a small amount of 1 microliter of 2% fluorescein. The tears contain about 10 microliter, so the dilution would give you the ideal concentration of 0.2%. Remember that the conjunctival cul-de-sac is only about 7 to 10 microliters, whereas one drop is about 30 to 50. So it's many times the volume of the cul-de-sac. And the normal tear volume, which dilutes the fluorescein, is also about 7 to 10 microliters. I'll just show you an example in my clinic assistant who has a normal ocular surface. So in this first video, I take a drop of diluent on the fluorescein strip and I put the entire drop into the eye. So you can see the quantum that's going in, and when he blinks, you can see the overspill. So too much fluorescein. The other way is what Professor Yokoi showed. You take the diluent on the strip, shake it off nicely, and gently just touch the palpebral surface, and this is all you need. So what happens when we do these two methods? You can see the fluorescence in the first method in the tear meniscus, but you can also see a lot of fluorescein in the tear film. And it's not difficult to imagine that if you had subtle staining on the corneal surface, this fluorescence in the tear film would hide it or mask it. On the other hand, when I use that 1 to 2 microliters, you see the adequate fluorescence. So that's enough to give you the fluorescence. But you can see the tear meniscus does not contain enough fluorescein to hide corneal findings. This is a normal surface, so there are no findings. But if we had fine punctate staining, the right picture would be a better way to detect it than the one on the left. So how do we look at this staining? When do we look at it? Basically, for fluorescein, you want to look at it somewhere between 0 and 1 minute, or ideally within 2 minutes. We all use the excitation blue filter, but as I'll show you, if you can use an yellow filter, this will enhance your ability to pick up the staining. For rose bengal and lissamine green, white light is good enough. So the technique to do this is to gently pull up the upper lid to look at the static staining that I'm talking about, because many important findings may be present in the superior cornea or the superior limbal conjunctiva. So what I'm talking about is the static use of the static staining with fluorescein, and what Professor Yokoi showed you was the dynamic use of fluorescein staining. So what exactly are we doing? We know that when we instill light into the eye with fluorescein on the surface, fluorescein absorbs light at 465 to 490 nanometers, and therefore we use an excitation filter so that the correct wavelength of light can be used to stimulate the fluorescein. The stimulated fluorescein emits fluorescence, and when you see the fluorescence, which is mixed with the blue light as well, and therefore it is a little muted. If you can use a yellow rattan barrier filter, which knocks off the light below 510 so that the blue light can be blocked, you can appreciate the fluorescence a lot better. Show you examples of this acanthamoeba keratitis, plain, blue, and yellow light. This is a DALP patient with a HSV keratitis who is recovering. This is you can see comparison once the yellow filter is on for the fluorescence. I will be frank with you though, if you have a good slit lamp and a good barrier filter, basically you can find where the yellow filter actually comes into its own is fluorescein to look at staining. Normally, when you use fluorescein and look at the conjunctiva, you see nothing in the blue light because of the intense reflection from the sclera. So the bottom picture is with the yellow filter, fluorescein staining of the conjunctiva, and on the top is the same eye, the same conjunctiva stained with lissamine green, and you can see that both are equivalent. So if you have a good yellow filter in addition to your blue filter, you don't need the lissamine and the rose bengal. Fluorescein alone is enough to look at the entire corneal surface. For those of us who don't have the yellow filter in our slit lamps, you can find these on the internet, and they're actually cheaper than this as well now. You have to hold this filter in front of the objective of your slit lamp so that when the light comes back from the patient's eye, the blue light can get filtered off and you can see the fluorescence better. The other thing was about the timing. We talked about that 0 to 1 minute or so. That is because initially, if you instill a little excess dye in the tear film, it blocks your findings. And if you wait for a minute or so, the excess dye goes away, and then you can pick up the staining better. On the other hand, in a very dry eye, when you put the fluorescein, it takes some time for the lack of tears to dilute the fluorescein, and initially it's dark and quenched, but with time you can see the staining. However, the 2-minute guide is important because if you wait too long, the fluorescein breaks through the abnormal epithelium, and as I told you before, it tends to diffuse, and at 10 minutes appearance like this changes the morphology of the staining that you see, and it's hard to make a diagnosis. This timing is not so relevant with rose bengal and lissamine because they do take some time to stain, so you want to wait up to 2 minutes, but they don't diffuse, so even if you wait a little longer, is all right. The other point you must remember is about pooling versus staining. This is somebody with the murines that I had been treating who came back with symptoms. So when I put the dye, it looked like the entire ulcer had reactivated. But remember, there's already a gutter from his past murine. So if you put in a couple of drops of some fluid to wash away the surface, you can see that what is actually happening is the small area of reactivation. The rest of the initial pooling was in the gutter that was already there. So remember pooling versus staining. So where do we look for this? Basically, the first grading scale that was used was the Van Bijsterveldt score. When he used rose bengal to stain the entire ocular surface, he divided it to 3 parts, and each of these he scored semi-quantitatively from 0 to 3 for a score of 9. The next is the OSS, or the ocular staining score, from the Jogren's Alliance. So here, in order to give equal weightage to the cornea, they added another 3 points to the cornea, one for the presence of confluent staining on the cornea, one for staining in the pupillary area, and one for the presence of filaments. So this became a total score of 12, 6 for the cornea and 6 for the conjunctiva. Then came bronze Oxford grading scale, where you have a series of photographic plates that you put up next to your slit lamp, and then you compare your patient staining with this to grade them from 0 to 5. And there are yet many more patterns of staining or grading. So this basically looks at the density of staining. For practical purposes, while we do need some kind of a scaling score, it may not be possible to go into that much of detail where they actually can count the number of staining spots. So what I like to do is I like to divide the ocular surface into 3 parts, but then I also like to divide the cornea into 3 parts. So it's basically 15, 3, 9, and 3. The reason I do this is because it's not just the amount of staining than the cornea that is important, but also the area of staining, which gives you important clues. Apart from this, you also want to look at the lid viper and the upper lid and the lid margin in the lower lid. So the reason why I said that the area of staining is important is because if you see staining only in the inferior 1/3 of the cornea, this often depicts lid margin disease because most of the toxic stuff from the meibomian glands and the blepharitis tends to pool in the tear meniscus and the adjacent cornea gets affected. Similarly, if you see changes mostly in the upper 1/3 of the cornea, this is from the upper eyelid, typically some allergic phenomenon. And if it's in the interpalpebral exposed area of the cornea, it's some kind of dryness with desiccation and evaporation. If you see this staining, but the upper 1/3 is upper 1 to 2 millimeters is also stained, then it means either it's a very severe dry eye, or if you don't see equivalent conjunctival staining, it means there is toxicity from the medicine or the preservative, because this enters the tear film, goes under the lid, and the protection of the lid is lost. You also want to look at the superior limbal conjunctiva for SLKC and the inferior bulbar conjunctiva for conjunctivochalasis related damage. The lid viper is this 2 to 3 millimeters in this flipped upper lid distalmost part of the mucosa, which is the pad that contacts the ocular surface, and this will stain in lid viper epitheliopathy. And the rose bengal staining of the lower lid margin is the line of marks. Normally, it is present at the opening of the meibomian glands, but as in this dry eye, as the meniscus decreases and shrinks, this line will move more and more posteriorly towards the posterior lid margin. So essentially, these are the questions that we asked. So we can use fluorescein staining for important information about the ocular surface, but to do that, we must first understand the basis of ocular surface staining. What is it that we are seeing? What does it represent? We must understand the dyes that we are using and their appropriate use, including the proper diluent and the timing of the examination. Use the appropriate examination technique, including the proper filters, and have some system of scoring or categorizing these changes so it helps you to follow up the patient sequentially. And as I said, if you have a yellow filter, then fluorescein is sufficient to look at the conjunctiva. But if you don't have one and want to use either of the other 2 dyes, today lissamine green is preferred over rose bengal because of the properties that I mentioned. Thank you very much for your patient hearing.
Thank you, Dr. Srinivas Rao. I think that was a mind-blowing lecture. And between Professor Yokoi and Dr. Srinivas Rao, we've completed the whole gamut of staining. And sometimes, like, I always feel that things which are not given in books, and even if you read 3,000 pages of a book, you get in just few minutes here when, somebody teaches you so well. So between the two lectures, I think we've said it all and we've learned it all. So thank you so much for that excellent lecture. So I think now we will take the questions which have come up before we go to Dr. Nikhil's talk. And there are questions on the Facebook, on the YouTube, as well as on the web platform. And it says that how far are the current modalities of dry eye management effective, and what will be I think that's a question which everybody asks. What will be an ideal tear substitute?
We'll ask Dr. Rajesh to answer that. Dr. Rajesh, are you there? Can you take that question, please?
Well, we are yet to have an ideal tear substitute, I would say. And an ideal tear substitute should be one which should have a good wettability and which should improve the retention of tear as well. And as I was listening to Dr. Yokoi also, because it should depend on the type of component, the component that is missing, the type of staining. It was very well taught that the breakup patterns that were shown by Dr. Yokoi, and maybe based on those breakup patterns, we can decide about the tear substitute, something wherein we can think of lipid abnormalities, so we can think of some lipid related substitute, some mucin related substitute for mucin deficiency. Maybe this is perhaps the future of the tear substitute. Right now, whatever we have, these are all for palliative measures, just to increase the volume of the tear film over the ocular surface. But I guess a more therapeutic approach will be to target the actual deficient component of the tear film.
Thank you, Rajesh.
Thank you, Dr. Rajesh.
Yeah. Dr. Srinivas, would you want to take the next?
No, I just wanted to ask Professor Yokoi, in Japan, do they have a standard tear substitute that they go to, or now that they're using the PFOD, is it different for each patient, that what drop that you would prescribe when he has a tear problem?
Yes,
like what Dr. Rajesh said.
Thank you very much for your comment and questions. In Japan, tear substitute which can enhance the expression of MAX16 and which can supply the ACAS tears are available, such as Dicuas and Levamipide. Levamipide can enhance the expression of MAX16 only. And I only introduced here the teapot, but via teapot we can propose most effective eye drops from our choice. So I wanted to show the tear substitute based upon teapot, but in India, I know that only hyaluronic acid is available at present. But in future, if you are accustomed with to the system of teapot, you can apply those available eye drops to the treatment for dry eye, I think.
Thank you.
We can play the video now, Mr. Sunil, and then we will move to the second part of our webinar.
Namrata, can I just ask Professor Yokoi a couple of questions related to his talk before we go on? Because this relates to his TFOD, and we're going to the other side of treating actually.
Sure.
So can I just ask him? Yeah. So Professor Yokoi, the question is that can a single patient show more than one pattern?
Hi. It is sometimes the case with line break. In the line break, you can also see the spot break and dimple break. But spot and dimple break in line break, it is the result because in line break show in acastia deficient dry eye, inflammation is accumulated on the ocular surface, which result in the shedding of MAC16, so leading to the decreased wettability. So we often see the line break together with the spot break and dimple break, but the most important breakup is the repeated breakup. Repeated breakup result in the superficial punctate keratopathy. We can see line break together with SPK, so the line break should be emphasized more importantly. So from the line break, even if there is a spot break and dimple break, line break correspond to, and the SPK correspond to the decrease ACAS deficient dry eye. So we should classify the finding into the decreased of ACAS deficient dry eye. Can you understand this? And
Yes,
also,
I do.
we often see the spot break and the dimple break and the rapid expansion together, but it is easy to classify into the decreased wettability dry eye because those breakup patterns correspond to the decreased corneal surface, wettability of the corneal surface. Okay.
Thank you. Yes, it is. And most of our slit lamps, the earlier versions in India, don't have the yellow filter. We understand that the yellow filter makes the the fluorescence a little better. So for your TFOD, is the yellow filter absolutely essential, or can somebody who wants to start just start with the blue filter alone?
Yellow filter is developed to see the conjunctival epithelial damage because conjunctival epithelia has the autofluorescence which interfere with the visualization of the damage. But for the cornea, yellow filter, when we use yellow filter for the breakup patterns, two more information can be obtained. So it somehow interfere with the interpretation. So the fluorescence without yellow filter is recommended.
Thank you. And your book, where is it available? Okay. And for the beginner who wants to go through the material before we start, your book, where is it available? Is it on the internet, or how does one access your book?
You can buy via Amazon.
Amazon. Okay, it's on the internet. Fine.
Yes.
Thank you very much.
Thank you very much.
Thank you. Namrata, shall we?
Just one question
sorry.
that Dr. Yokoi mentioned in his talk that you can also use artificial tears to wet the fluorescein strip. So if you use an artificial tear, do you have any choice of preference whether you would use CMC or hyaluronic acid or HPMC, and does it make a difference in the observation?
I haven't tried it yet, but saline is enough to instead onto the fluorescent strips.
I think Dr. Nikhil, there in Japan, artificial tear, by artificial tear, they mean the balanced salt solution saline.
Yes, exactly.
Dr. Srinivas Rao made it very clear that CMC ideally should not be used because then it will be a confusing picture.
I think we'll go on, Namrata, to the next talk, Nikhil's talk.
Yeah. So I would like to now invite my very good friend and my batchmate, Dr. Nikhil Gokhale from RP Center. Now, of course, he's at Gokhale Eye Center. He's going to be talking about corneal regeneration in dry eye management, why it matters.
Can you see my slides?
No, Nikhil, your screen is there, but your laptop screen is there, but the slides are not there. Yes.
You can see them?
Yeah. Make it in slideshow, please.
Yeah. So I was a little puzzled initially when I got this topic of regeneration. But then I think I tried to look up at what is expected. So as we just had very good talks by Dr. Srinivas and Dr. Yokoi and Himanshu, we realize that ocular staining is very essential when we look at diagnosis of dry eye. And as we saw, we use various dyes to look at the ocular surface. And it's also very essential that the surface staining gives us some idea about the degree or severity of the dry eye. For example, a very, very mild dry eye will have no staining of the ocular surface, and a very severe staining would be seen when you have a grade 3 or a grade 4 dry eye. So, and based on the extent of staining, it might also help us to decide what medications we might use for a given patient. And therefore, we might see some patients of dry eye who have extensive staining. There may be other pathologies of which cause dry eye where we don't see a significant amount of ocular surface staining, though we may still see a good number of symptoms as regards to the patient. As Srinivas showed us, we often look at these erosions when we try to do fluorescein staining. And they could be very mild erosions in the lower part of the cornea or in the interpalpebral area, and then we could have very severe staining and large areas which are staining, and even you can have filaments which might be there. So basically, we look at the ocular surface staining not only for diagnosis of dry eye, we help it. It also helps us to grade the type of dry eye, to decide what treatment we would like to use for a given patient of dry eye. And then when we follow up this patient, the ocular surface staining helps us to know how is the treatment going on and how is the response to the medical treatment that we are doing in a given patient. I was just wondering that why do we get epithelial erosions in dry eye? So some of the factors that came to my mind could be, there could be mechanical factors, by which I mean a frictional loss, which could be because the lubrication isn't adequate on the ocular surface, or it can be sometimes because the epithelial surfaces have become roughened up, or there is some keratin. There could be neurotrophic factors. We know that in dry eye, there is a decrease in the subbasal nerve density, and therefore these factors might slow down the epithelial recovery. We could also have epithelial erosions because of inflammatory cytokine-induced damage to the ocular surface epithelium. And we all know that a lot of medications and preservatives may have toxic effects on the corneal epithelium, and therefore give rise to ocular surface staining. As of now, despite a lot of research, when it comes to treating dry eye, very often we restrict ourselves to using lubricants and only lubricants. We need to understand that that's pretty palliative, as one mentioned, and they just sort of give a symptom type of relief, maybe a temporary symptomatic relief. However, they do not address many of the underlying mechanisms that are responsible for the dry eye pathology. So if we need to address how we should look at treating epithelial problems, or how we should improve the ocular surface stain scores and improve the patient's symptomatology when it comes to a patient with dry eye, I think we need to look at each mechanism and see how we could target so that the staining goes down and the patient is more comfortable and feels better. So if you are looking at mechanical pathology, then you could try to use a better lubricant, and also use something which can help the epithelial regeneration so that the recovery is faster. If you look at neurotrophic factors, maybe you need to look at mechanisms by which you can induce neural regeneration. And of course, you will need to use anti-inflammatory therapy so that you can target the inflammatory cytokines on the ocular surface. And of course, you need to avoid medications and preservatives which may be toxic to the ocular surface epithelium. So whenever we talk of dry therapy, we say, well, we need to reduce the inflammation on the ocular surface and on the in the lacrimal glands. We try and aim to normalize the tear film and stimulate the healing of the epithelium on the ocular surface and improve the neural loops and feedbacks. So as Srinivas mentioned, the corneal epithelium is a tight epithelium with glycocalyx on the surface, and we have tight junctions, which is like a barrier effect. And then we have the ocular surface is richly supplied by the subbasal nerve plexus in the cornea. And we know that when we have a patient who has a chronic dry eye, there is a loss of the nerve density, and it correlates with the ocular surface staining in these patients. So what does really happen when there is a corneal epithelial breakdown in a given eye? So whenever there is a corneal epithelial injury, it probably gives an afferent impulse in the corneal nerves, which then releases certain factors such as the nerve growth factor, substance P, and the calcitonin gene-related peptides. And in the presence of growth factors such as the epithelial growth factor and the TGF-beta and several others, there is a release of fibrin, fibronectin, and hyaluronic acid. So there is an upregulation of pathways which lead to a production of fibronectin and hyaluronic acid, which then form a temporary scaffold which helps the epithelial cells to slide over and heal and bridge the defect. So this temporary scaffold which forms activates the cells at the edge of the epithelial breakdown to rapidly spread over. And it also sends signal to the transient amplifying in the limbal stem cells in case there is a significant epithelial breakdown. So eventually there is epithelial sliding and regeneration, and the surface does heal up. We know that hyaluronic acid is important for ocular surface regeneration, and it binds to the CD44 receptor, which is there in the corneal and the conjunctival ocular surface epithelium. And this receptor tends to get upregulated whenever there is corneal injury. And therefore, the hyaluronic acid plays a very important role in healing of the ocular surface. So as I showed you in the earlier slide, basically just to show the sequence of events, the cell deficient site, if it is there, it will then basically cause expression of fibronectin, which then forms a sort of a matrix on which the cells can very quickly and easily slide and regenerate. And we know that fibronectin is expressed in wounded corneas, and it helps the epithelial healing, as has been shown in several publications. And once the epithelium does grow over the bare area, it then moves vertically and forms the 5 or the 6 layers of the epithelium, and it also differentiates into the various type of cells that we see in the epithelium. Here we look at how does sodium hyaluronate really help the epithelial healing process. So as I mentioned earlier, hyaluronic acid and fibronectin and CD44, they're all overexpressed whenever there is an epithelial injury. So when we use exogenous hyaluronic acid as eye drops, there is a basically binding of the hyaluronic acid to the fibronectin, which is laid down. And this basically again increases the way by which the epithelium can adhere, and then cells can migrate rapidly. In literature, it has been shown very clearly that a fibronectin with a hyaluronic acid combination has a synergistic effect, and it aids rapid epithelialization. And if you use any agent by which you can block the fibronectin or the hyaluronic acid molecules, there will be a delay in the epithelial healing. Based on the understanding, we have several studies which then show us how the epithelial wound healing can be modified by using hyaluronic acid polymers in an eye where there is an epithelial injury. We have several clinical and experimental models which show that the healing of an epithelial breakdown or epithelial defect will be enhanced and will be much more faster when you use hyaluronic acid in patients or in the animals where their epithelial damage has been created experimentally. And the sodium hyaluronate, as we know, comes in different concentrations and in different molecular weights. And how does that really affect the epithelial healing? And this has been studied experimentally, and they found that the molecular weight does not really change the way the corneal epithelium heals. However, when you look at the concentration of hyaluronic acid, about 0.1% concentration was probably better than a 0.01 or a 0.05% concentration. So you need an optimal concentration of sodium hyaluronate, which will help the corneal healing process. We also know that apart from the healing effects, the sodium hyaluronate also prolongs the tear film stability, and it might prolong the tear film stability for up to 3 to 4 hours following installation. So what this really means is that, for example, as we mentioned, the frictional loss, or we mentioned the mechanical sort of abrasion of the corneal epithelium because of the dry eye. So if we have an agent which keeps the ocular surface moist and lubricated and healthy for about 3 to 4 hours following installation, probably using the drops 4 to 5 times a day during the waking hours might be a good option to prevent ocular surface injury. When we look at some of the properties of sodium hyaluronate, basically it's a sponge-like structure which has a high affinity for water molecules. So it's a sponge which holds the water together, and it releases the water slowly from the sponge into the tear film. So it's like a slow release mechanism which keeps moisturizing the tear film for maybe 4 hours or 3 hours following installation. And this moisturization uniformly spreads across the ocular surface and helps to sort of maintain and preserve the ocular surface epithelium. So by improving the tear film stability and maintaining the wettability of the surface, it also helps to improve epithelial healing due to its biologic properties. So it has a sort of a protective effect by creating a healthy tear film for about a few hours following installation. And then we have several clinical articles or clinical data which document the similar observations in clinical studies, where they found that when you use sodium hyaluronate, it improves the symptom scores and reduces the ocular surface staining in patients with various forms of dry eye diseases, including the Sjogren's and the non-Sjogren's variety of dry eye. And these patients have done better than the placebo or in other studies compared to other polymers that are available for dry eye. So basically, I think what we need to understand is that when you use hyaluronic acid based tears, you not only provide hydration to the ocular surface, but you also provide a healing response to the ocular surface. And we know that dry eye is basically revolving around the tear film instability, the tear film related problems which give rise to symptoms, and the corneal epithelial breakdown, which again give rise to pain and other symptoms of dry eye patients. And therefore, by improving the tear film stability and accelerating wound healing, I think hyaluronic acid is a very good polymer that will help our patients who have dry eye. Of course, we need to address the other mechanisms as well. So we definitely use anti-inflammatory therapy, maybe mild steroids, maybe topical cyclosporin when it comes to treating patients who have dry eye. And we also need to look at neural regeneration. We have data to say that when you use anti-inflammatory therapy such as cyclosporin, there is an improvement in the nerve fiber density, and there is neural regeneration in patients who are treated adequately. We can also say probably that if we treat patients with a good tear substitute and help in promoting the epithelial healing, probably it will also help to suppress the inflammatory responses that are often triggered by an epithelial breakdown. We also need to look at toxic effects of medications on the ocular surface. And I think the most important factor here is the ocular surface health. So whenever we have a patient where the ocular surface is unhealthy, for example, a patient who has dry eye, all these other factors become less important, and these patients quickly develop ocular surface toxicity, maybe because of, let's say, a benzalkonium chloride or an epitheliotoxic antibiotic or so on. We know that patients who have good ocular surface health are often able to sustain long durations of treatment with multiple drops, often with preservatives, but a dry ocular surface has very poor tolerance to these medications, which may be toxic. And we need to eliminate these toxic medications from the ocular surface and replace them with more friendly polymers and artificial tear substitutes which have minimum preservative. And at the end, I would like to say that whenever we treat a dry eye patient, I would like to see less and less of ocular surface staining once I start treatment for the patient. And I hope that as science progresses, we come to a situation where we probably don't see staining once we treat our patients well. And that would be a great achievement for all of us. Thank you.
Thank you, Nikhil. I think that was an excellent talk, and I think it highlights the importance when we're dealing with the ocular surface of trying to understand what it is that is happening both at the surface level and at the molecular level, because only when we truly understand that do I think that we can actually improve our treatment options. So knowing that there is a hyaluronate is one thing, but knowing how to use it appropriately, when to use it, and why are we using it in that manner, I think is equally important. And I think Nikhil's talk was excellent on that. So I think we'll continue with this next two talks, which talk about the treatment of dry eye in various situations. And then we'll come back to other questions as one lot on treatment options. There are already some coming up. We can take that after this. So I'm going to now invite Namrata for her talk on the management of a very severe form of dry eye, a very particular form, a particular entity, the Stevens-Johnson syndrome, which unfortunately India is seeing a lot of. So she's going to talk to us about the management of Stevens-Johnson syndrome itself, and obviously the dry eye that comes with it. Dr. Namrata, please.
Thank you so much, Dr. Srinivas Rao. I'll be talking to you about management of Stevens-Johnson syndrome and toxic epidermal necrolysis. The incidence is 2 per million, but we see a lot more in India, and also we see it in a more severe form as compared to the West and the East both. It is associated with the use of antibiotics, anti-epileptics, and NSAIDs, and CMI and antibody-mediated immunity is involved in it. Now, it is of various forms depending upon the severity: erythema multiforme, SJS, toxic epidermal necrolysis complex, and frank toxic epidermal necrolysis. Acute SJS, the ocular symptoms will present within 2 to 6 weeks after symptoms. The ocular manifestations are seen in 50 to 80% of the cases, and 1/3 would have long-term sequelae. So patients may have bilateral conjunctivitis with conjunctival and corneal ulcerations, hyperemia, pseudomembranes, early symblepharon, fornicel shortening, and mebomitis. And this is a very important paper on natural history of SJS published by Dr. John Dart's group. And just to summarize, these are the manifestations. There will be variable degree of scarring, which will lead to dry eye. And if you have a picture like this, you'll probably just label as dry eye and not as acute SJS. And this can lead to a variable amount of conjunctivalization, keratinization, with fornix shortening leading to entropion and limbal stem cell deficiency as well. And this is the absolutely bone dry eye. So the effects are there on of dry eye, of trichiasis. So there can be epithelial defects, there can be melts like this, and then there can be vascularization and lipid keratopathy and delayed surface failure, which can be seen in these pictures along with limbal stem cell deficiency. And sometimes you can even have recurrent SJS, severe inflammatory ocular episodes as well, which are acute episodes which are on chronic SJS. And the disease is indistinguishable from ocular cicatricial pemphigoid, which again can present similarly as seen in these pictures. Then there can be late scleritis also, which is more of, again, an immunological response. And it can be an interplay of all these features which I have already discussed. Now, the goal of therapy in these cases is to control acute inflammatory reaction. This is very important because if you control it, treat it in the acute phase itself, you would probably not have a chronic sequelae. And that is the reason why we thought of doing this presentation. And so timely slit lamp examination is very important for epithelial defects. Regular sweeping of the fornices is important, and one must prevent formation of pseudomembranes in symblepharon. So the treatment modalities are following, and I would be going through these as we would go through the cases. So as soon as you have an acute case of Stevens-Johnson syndrome, which is referred to you or comes to be seen by you, important thing is that you do an immediately amniotic membrane graft. I think that has a very important role to play, has been shown in now multiple studies. And topical steroids I like to give, although people do say that the role is uncertain, and even IV methylprednisolone has a role to play. Now, immunosuppression has a role to play, because what happens if you don't immunosuppress them, they would go into chronic sequelae, and more so when there are recurrent conjunctival inflammation in SJS and in acute SJS when there are inflammatory episodes. So although in details we cannot discuss it, but this is the immunosuppressive therapy that we use. And it is, all of them have different mechanism of action, and avoid mixing the drugs in the same color group. So you could either start a prednisolone or steroid and combine it with immunosuppressive agent if the inflammation is prolonged, and then the steroids can be tapered and the immunosuppressant agent can be given. And this is the systemic immunosuppression chart that we used to follow at Moorfields Eye Hospital, wherein I learned the principles of SJS, ocular SJS specifically. So all the side effects would come into this, and these side effects are listed at the back. So every time the patient comes, you know what is the dose, and you know what is the side effects and what you have to monitor. And these are then slowly tapered as the inflammation is taken care of. And the endpoint of inflammation is that the eye should be white. It should not be a hot, angry looking red eye, congested eye, inflamed eye, inflammation of the ocular surface, conjunctiva, as well as cornea. So, and when you have to taper it, then you again go in a step ladder pattern. So you start with Depson or sulfapyridine in mild inflammation. If it doesn't work, then methotrexate, then azathioprine or mycophenolate. Mycophenolate is safest in these cases, then cyclophosphamide, and followed by IV immunoglobulins. There are cytokine inhibitors which have been tried, but of course you require the help of an immunologist if you try to give these. We did try to study the conjunctival microbial flora in ocular SJS, and we found that staph was the one which is most common, because the ocular surface is altered, so the microbial flora is also altered. Now, lubricants do have an important role to play, and in the various studies on SJS, these were the lubricants which have been tried. So you can see that most people preferred preservative free, because the frequency has to be, it has to be very frequent, and it could be either a CMC, hypomellose, sodium hyaluronate, or any other agent. And IV pulse therapy by Dr. Kinoshita's group has shown that it does decrease inflammation. Again, there are not enough evidence for systemic steroids and IV immunoglobulins because of lack of studies. We did do a study of use of topical cyclosporin in acute SJS, and all the parameters we found, this was a randomized controlled study, were comparable except for corneal vascularization, which we found less in cases where topical cyclosporin A was given as compared to the control group. AMG has a very important role to play, and this was the randomized controlled study that we did for AMG in 50 eyes. And in one group, we did AMG, and in the other group, we did not do AMG. And we found that the tear breakup time was better in those cases where we had done AMG. So Schirmer test was also better in those cases where we had done AMG. And so was conjunctival congestion, which was much less. And you can see the cases where AMG was done is looking so white and so uninflamed as compared to the cases where AMG is not done and only medical therapy was done. Again, Simlifron was more in those cases where we had not done an amniotic membrane transplantation, and this is the medical therapy group. Corneal haze was more in cases where we had not done the amniotic membrane transplantation, and this is the medical therapy group. Again, vascularization was less in those cases where amniotic membrane transplantation was done. And this is the group where it was not done. So you can see that conjunctivalization, limbal stem cell deficiency is also more. And so it is important in these cases to do amniotic membrane transplantation in the acute phase itself to prevent all these complications. And we started to think that it would now, if we look at the study, it will be ethically wrong not to do amniotic membrane transplantation in these cases. Look at the keratinization which has occurred in the medical therapy group. So it is very important that AMT be performed in this. The second part that I want to highlight is outcomes of COMET in eyes with chronic SJS, which has been published just this month in American Journal of Ophthalmology. Again, in this case, in this we looked at 45 cases, and we described a new method of evaluation of grading of ocular SJS in patients with SJS, mainly because our cases tended to be more severe. So in the previous grading where Gregory has given grades which are less severe, he's gone from score 0 to score 3. but we like to add 4 and 5 also to it and look at this gamut of cases which is more severe, and you cannot put them in same as grade 3. And this has been published. So whatever COMET panels we took, we did subjected to the molecular studies, and this is the outcome. Patients did become ambulatory, and they were removed from the blindness category after doing COMET. And although they will not obtain 6/6, but still they will be ambulatory and will have 6/60 or 6/24 vision, which is good enough. And for all the parameters, we found that there was a difference, whether it was opacification, vascularization, best corrected visual acuity. And again, look at all the corneal parameters, the eyelid parameters, the conjunctival parameters, where COMET did make a difference in these cases. So I would like to conclude that acute SJA should be managed by AMT best, and that way we can prevent a lot of dry eyes and a lot of limbal stem cell deficiency. And different grading is required in Indian population as our diseases are more severe. COMET has a role to play in improving ocular surface parameters and the visual acuity. And like for all conditions of dry eye, lubricants are the mainstay for the symptomatic treatment. And these are some of the review articles that have been done by SJS, where our group was a part of it. Another one, this on survey of ophthalmology. And I would like to acknowledge Professor John Dart, who introduced me to this ocular manifestations of SJS and OCP when I did my fellowship with him. And the entire team from RT Center AIMS, as well as from the main department AIMS, who are part of all these studies that we have conducted. So thank you very much for your kind attention.
Thank you, Namrata. That was a very impressive body of work on what is essentially a fairly desperate condition, and particularly that last paper that you showed seems to offer a lot of promise for these people with end-stage dry eye, really. So we're going to the last talk of the day. So what Dr. Namrata spoke about was a not so common but very severe condition. Dr. Rajesh is going to talk about a more common but maybe not so severe condition, something that we create ourselves when we do all these ocular surgeries and traumatize the nerves on the surface. He's going to talk about the management of the post-surgical dry eye. Dr. Rajesh, please.
Thank you, Dr. Rao, for having this wonderful webinar, wherein, after attending to all these talks, it was a huge learning experience. And I would like to present on post-surgical dry eye. Now, as surgeons, when we do surgeries, the main concern that we have is to improve the visual acuity. So the visual outcome is something which is our main concern. And if the vision is good, and if we have done a refractive procedure, the flap is in proper position, no striae, no folds. If we have done a cataract surgery and the IOL is well centered, if we have done a retinal surgery, the retina is well attached, and if we have done a trabeculectomy, the IOP is normal and the bleb is well formed. So we are satisfied, we are happy about it. But the same thing doesn't happen with patients many times, and patients are very much keen, very much concerned about their comfort. And many times these patients after the surgery, in spite of a very good visual outcome, in spite of a very good anatomical outcome, some of these patients, they do have symptoms like irritation, redness, and foreign body sensation. And that is basically because of the post-surgical dry eye. That is a very important issue following these procedures. Now, these patients can have symptoms that can be very irritating and disabling, and that can affect the quantity and quality of vision. A case of a premium IOL cataract surgery done, poor ocular surface will have a poor quality of vision. Laser refractive procedure done, but the ocular surface is not very good and having dry eye, then the patient will not have a good quality of vision. And these patients, those patients who are at risk preoperatively and not properly evaluated, they have very severe dry eye and ocular surface disorder. The surgical procedure aggravates the dry eye. And it can be seen, as I said, after many surgeries. So corneal refractive surgery is something wherein post-operative dry eye has been reported very often. Now, before going actually into the causes of the dry eye in corneal refractive procedure, I'd just like to highlight the tear secretion neuronal loop. The cornea is supplied by the ophthalmic division of the trigeminal nerves, the trigeminal nerve, and the stimulus goes to the brain if there is some element of dryness. Now the brain sends impulses to the lacrimal gland, and the gland secretes tears, and this is how it is maintained. But if the nerves which are sending the signals to the brain are transected, are damaged, in that situation, the whole loop gets affected, and there is a reduction in tear secretion. So in LASIK, wherein we create a flap, we cut the nerves, there is reduced corneal sensation, and there is decreased feedback to the lacrimal gland, and that is why there is reduced tear formation. Then there are other factors like there is subtle inflammation on the ocular surface, there can be drug toxicity, there can be pre-existing dry eye in these patients. Particularly some of these patients, some of these individuals who have undergone refractive procedure, they are on long-term contact lens, and that also affects the ocular surface many times. Now, there are other factors, there are many factors in LASIK which modifies the severity of dry eye or the ocular surface disorder. Like if you have a narrow hinge flap, then in that case, this means that you have cut more. In that case, you will cut more of nerves, and then the chance of dry eye is more, because it is directly related to the amount of denervation that you are doing. Then surface ablation cuts less of nerves, and I'll come to the studies that have shown that, and that is why the dry eye is less in comparison to LASIK. Initially, when femtosecond laser came, there was a lot of euphoria that probably it will have less of dry eye, but there are multiple studies now that have shown that the element of dry eye is seen in both, and it is not significantly different between the femtosecond laser or the microkeratome LASIK. Now, this is one interesting study which has done in vivo confocal microscopy, and have found out that the subbasal corneal nerve plexus, which it was a long-term study. They studied the subbasal nerve plexus and found out that over a period of 10 years also after LASIK, the subbasal corneal nerve plexus did not completely recover to its preoperative pattern. And both main nerve density and the nerve branches density continue to be significantly lower compared with the virgin corneas after a mean 13-year follow-up. Although other parameters had recovered, but the nerve density was not as good as it was in a virgin cornea or preoperatively. Now, multiple studies have been done, and this is one study by Francisco et al., which is a review article which has evaluated most of the studies. It's a very interesting review article to read, and there are various studies that have been quoted in that. And in that, studies have shown that in PRK, what happens that you debride the epithelium and then you ablate the stroma. Now, in cornea, you have nerve plexus at 3 levels. One is at the deep stromal level, when the main nerve enters into the stroma, gets demyelinated after 1 millimeter of its entry into the cornea, and then forms nerve plexus in the stroma. And then the branches, they move up and they form the subbauman plexus. And then further the branches, they pierce the baumans and they form the subbasal or the epithelial plexus. Now in PRK, you debride the epithelium and you ablate. So what you damage is that most of the subbasal plexus and part of the subbauman's plexus. In LASIK, what you do is that the stromal and subbasal nerves are both severed during flap creation, except at the area where there is the hinge, and then subsequently the excimer laser will ablate the underlying stromal nerve plexus. So quite a significant amount of denervation is seen in LASIK. And it has been seen that less than 10% of original subbasal nerves remain in the operated cornea, and the subbasal nerves left in the flap may undergo a gradual degeneration in the early postoperative period. And in SMILE, what happens that the stromal nerves are damaged and the superficial plexus is very minimally affected, except in the area wherein you create a small pocket through which you extract the smile lenticule. And it has also been seen that the plexus is more dense in the peripheral part of the cornea. All these plexus are more dense in the peripheral part of the cornea in comparison to the central part. So studies have shown that hyperopic correction causes more nerve damage than the myopic ablation profile. And as far as nerve regeneration is concerned, in PRK, what happens is the epithelium and the most anterior stroma is removed. So the new neurites, they arise from the severed nerve endings, and they start forming very fast. The new nerve fibers start to emerge as early as 1 to 7 days. And in vivo confocal microscopy has shown that by 7 days, you start seeing the sprouts and the nerve re-innervation is quite significantly done by 3 months' time. However, the morphological and functional changes may still be present even up to 1 year time. In LASIK, what happens is that the nerve regeneration starts in the peripheral margin of the flap, and it moves in a centripetal direction towards the center of the cornea. Now, the denervation in LASIK is quite significant during the procedure, and it stays like that for nearly 2 to 3 months. And the regeneration starts. However, what happens that the regenerated nerves coming from the stroma below the LASIK interface, they are unable to cross and interconnect with the remaining nerves inside the flap. And the subbasal nerve density takes more time to recover in LASIK than in PRK. And studies have shown that even up to 5 years or 10 years after surgery, it has not returned to its pre-surgical values. Nerve fibers that do not penetrate in SMILE, what happens that you create a lenticule. So what happens that the area, the superficial plexus is mostly spared. Only in the area where you make a cut, the plexus is damaged. So it is mostly spared, and only the deeper stromal plexus is affected. So that is why the nerve damage is much less in SMILE, and that is why in the immediate post-op period, the amount of denervation is quite significantly less in comparison to LASIK. As you can see here, this is what the graph shows, and this is a study done for up to 5 years, and what you can see is that this PRK by 6 months time, it is almost 50%, it comes to normal. This is about the re-innervation, and by about 2 years time, it is close to normal, but it doesn't reach the normal value till 5 years. And in LASIK, even at the end of 5 years, it is quite significantly less than normal value. SMILE has a lesser follow-up. By the time this paper had come, it was only 6 months period. So it showed that more than 50%, about 60 to 70% of corneal innervation is done in SMILE after 6 months. And this is about the corneal sensitivity. Now, what happens that corneal re-innervation may not be complete, but the re-innervation may be adequate enough to improve the corneal sensitivity. And that is what happens in PRK, as you can see here, in 6 months time. In 6 months time, 3 to 6 months time, you can see here that the corneal sensitivity is quite normal. And that is why you require less lubrication in PRK than as you see in SMILE. And there are various studies which have shown that PRK has a better re-innervation than LASIK, and similarly SMILE has a better corneal nerve regeneration and better sensitivity than LASIK. And this is one survey that was conducted in patients dissatisfied because of LASIK, and 1 out of 5 individuals who were dissatisfied because of dry eye following LASIK. Now, apart from refractive procedure, corneal refractive procedure, even cataract surgery these days have shown after we have attained the 6/6 and N6 vision, patients complain of irritation and watering and feeling of foreign body sensation. And there are various factors that are responsible for causing dry eye in cataract surgery. Like cataract patient population is older, has a high chance of meibomian gland dysfunction. Females are in the perimenopausal age group. They can be coexisting glaucoma, and they might be on anti-glaucoma medication. Then the lifestyle is such that you are always in air conditioners wherein the humidity is less, and so the dryness is increased. So all these factors, they lead to making the patient predisposed to dry eye. And once you have done a cataract surgery, you cut a little bit of nerves, you alter the corneal curvature, and the breakup is fast. And all these factors, particularly when we try to add many things like limbal relaxing incision, the corneal incision for astigmatism, etc., to make the uncorrected visual acuity 6/6, we end up cutting more nerves, and there is chance of dry eye. This is one study which has shown that the area wherein we make the incision, the corneal anesthesia is more in comparison to the cornea, which is distant away from the area of incision, and the breakup time showing a drop immediately after the surgery in comparison to the preoperative value, and even the goblet cell density has shown a decrease after cataract surgery. And this is one study which has shown that many of the patients in this study, they had shown symptoms related to dry eye following cataract surgery. Even after glaucoma surgery, a lot of patients, they do show symptoms of dry eye because you use antimitotic agent, there is risk of loss of limbal stem cells, there can be large bleb which can cause rapid breakup. And even after retinal surgery, since the retina surgeon many times debride the epithelium, they cause conjunctival damage, goblet cell damage, and even these are prolonged surgeries. And this is one study which has shown that phototoxicity of the microscope light can cause damage to the ocular surface. And this is one study which has shown that in retinal surgery, when silicone oil was injected, there was more chance of dry eye. And of course, drug toxicity plays an important role. So all these factors can lead to occurrence of dry eye. As the previous speakers have very nicely mentioned about the management of dry eye, I will, due to paucity of time, I will go fast in this. And as we all know that the lubricants are the mainstay of treatment of dry eye, and an ideal polymer, as I had mentioned earlier, is yet to come. But a lot of polymers have been used as far as reduction of symptoms is concerned. Carboxymethylcellulose has been used for the last so many years and has been found to be quite effective. And for the last couple of years, we have found that hyaluronic acid has come up with good outcome because of a high molecular weight. It stays longer on eye. There's long chains, twisting ribbon structure, and it can hold water. And it has a good mucoadhesive property, and it restores epithelial integrity, which was very well discussed by Dr. Nikhil, so I won't go into details of it. But hyaluronic acid is something about which most of the cornea surgeons are quite excited about. And there is always subtle inflammation, which can be a cause of dry eye, or because of dry eye, as Dr. Yokoi was mentioning, there can be increase in inflammation. Whatever it is, in order to reduce inflammation, we do require some anti-inflammatory in the form of topical steroid for some time, and cyclosporin has been found to be quite effective in these conditions. So in summary, dry eye can be seen quite commonly after ocular surgery, and all these ocular surgeries, the anterior segment surgeries as well as the posterior segment surgeries, they can cause damage to the ocular surface. The controllable factor in these is to reduce drug toxicity and to treat the preoperative dry eye so that it doesn't become very severe after the surgery. Preservative-free lubricants are the mainstay at this point of time, and if there is subtle surface inflammation, reduction of surface inflammation is to be done. But most importantly, all these patients have to be educated, they should be counseled and instructed about the risk of dry eye following any ocular surgery. Thank you very much for your patient listening.
Thank you, Dr. Rajesh. I think we've come to the last talk. There are a few questions that I thought I will, that the audience have been asking. Maybe I'll ask Dr. Rajesh first. There was a question about the management of filamentous keratitis, which we sometimes see after we do a surgical procedure on the eye. So what are the reasons and how do we manage that? What is your advice?
See, most of the procedures, they can cause dry eye, but if the patient has, some patients might be having dry eye preoperatively. Such patients have a chance of developing very severe dry eye. And filamentary keratitis usually occurs in patients who have quite severe dry eye. So if there is a filamentary keratitis, apart from the lubricant eye drop, like maybe hyaluronic acid, we can use acetylcysteine eye drops to dissolve the filaments. That is quite effective. Sometimes even the bandage contact use can dissolve the filaments. Having said that, the root cause is dry eye, for which the lubricant eye drop and any other dry eye things like cyclosporin eye drop can be quite effective. But acetylcysteine, I have felt that whenever there is a filamentary keratitis, it works quite well.
Thank you. Himanshu, maybe you can take this. There are a couple of people who are asking about what are the newer modalities of managing dry eye. Your thoughts in the Indian context, Himanshu, what are the newer modalities that we can apply currently?
So by modalities, I assume they are referring to the treatment modalities and not molecules. So
it's probably both. I think they just said modality. Sure. So, I mean, you can address both then probably the molecules as well as the other options that you're mentioning. Sure.
So basically, the treatment modality-wise, majority of things which has happened in recent past has happened in the field of MGD-related dry eye. And many of the instruments which we have seen, what like few of them, LIPIFLOW and those kind of devices, what we have seen, they have come in the field of MGD-related treatment and dry eye. Such kind of device again are based on the heat which can be delivered through either the direct heat or indirect heat in the form of different spectrum of light, visible and invisible spectrum of light, and basically to increase the temperature in the meibomian glands to liquefy those polar lipids which have become sort of solid. And then some of them, they do have capability to express them out using thermal pulsation, using the pulsation, and which helps us to reduce the blockage. Having said that, most of these devices, they are one-time treatment. They are not one-time treatment device. I must clarify that part, that they have a finite lifetime for which they can work. So whatever we do, we must know the device which we are using, and we must counsel the patient that there are chances that we have to repeat the similar treatment in future. Also keeping in mind that whatever we treat, we are treating the effect and not the root cause. So unless we treat the root cause, the such things are going to continue happening. So if the root cause is infection, treating the infection would be equally important. If root cause is the composition of the lipid, by altering the composition, maybe omega-3 and those things would be important. So the MGD part, where most of the instrumentation has come, has helped us treat MGD in more elite way, but keeping in mind that some of them have limited outcome for the time period. In terms of the molecules which have come, unfortunately, there are not too many molecules which we have got, but rebimipide is one which we got, like what we were discussing earlier. Rebimipide also is not available in all the places, and not many of us have equal experience with different brands. So that's another thing which is quite interesting in our country, that even the formulations are a little different, where you have suspension in Japan, we have clear solution here. The effectiveness of some of them are questionable. So That's another thing to keep in mind. We certainly need suspension lubricants, basically having an oil-based component as well as the aqueous-based component, which are there in the Western market, but somehow which is still not coming to the Indian market.
Thank you, Himanshu. I think there's a follow-up question on this. I'll ask Professor Yokoi this. Basically, you did mention with the TFOD that we can recognize mucin deficiency dry eye with a breakup pattern. In the Indian context, like Himanshu said, we don't have diclofenac as yet, and whatever ribamycin we have is not very effective according to some of our experience. So in the absence of these two agents, if we do recognize a mucin deficiency dry eye, is there some way in which we can manage that patient better?
You have to unmute yourself.
You're on mute, Professor. You need to unmute your mic. We can't hear you.
Okay. Can you hear
better
me?
now. Thank you. Yes, thank you.
More than 10 years ago, we don't have diclofenac and ribamycin, and we only have hyaluronic acid. In that period, we see lots of short BUT dry eye, which is related to decreased wettability. But we treat such kind of dry eye using punctal plugs. But when we insert punctal plugs to the upper and lower puncta together, patient complain of reflex tearing. But they can, compared to the dryness, tearing is acceptable. So, so you can treat with the punctal plug, I think.
Just follow on to that, there's a question by Dr. Hijab Mehta. She says, what is the panelist opinion on cross-linked hyaluronic acid eye drops?
I have no idea. Maybe Nikhil can answer that. He must have done most of the...
Cross-linked hyaluronic acid, you think has a role?
Very frankly, I haven't gone through the literature to really...
No, I think one of the company, they promote their hyaluronic acid as a cross-link molecule. Frankly speaking, we would not have scientific knowledge about the truth in the claim. But the interesting part is that even if we increase the chain, as I think Dr. Nikhil was showing, that there is a sweet spot. You just can't keep on increasing the molecular weight of a drop, and that can have better effectiveness. At the same time, one thing which Dr. Nikhil said was very interesting part, which was the spongy effect of the sodium hyaluronate. So hyaluronic acid does require aqueous component also along with that to have the wettability of the surface. So that's the part where we increase the molecular weight a lot. It's not going to directly have the same effect on the ocular surface. And also previously what we were discussing, that in absence of drop, which are therefore especially the wettability type of dry eye, again, Dr. Nikhil had touched up this thing that anti-inflammatory, most of the time this mucin expression is less when the cells are sick. Transmembrane mucin, which is typically from the apical region of the glycocalyx of the cells, reduces when the cells are inflamed. So anti-inflammatory also have a role in such cases where we reduce the inflammation, the mucin expression does improve.
Okay.
Can I just relate to this? Can I ask one question? We do have 0.1% hyaluronic acid and 0.18. So any experience of the difference in outcome with these two?
I don't think we have studies that, but one thing I strongly believe that combination of hyaluronic acid with a low molecular weight lubricant is equally important to have wettability as well as and that's what I think in Japan they add in balanced solution with sodium hyaluronic acid.
I remember some papers which were talking about the formulation of these drops in the early stages. So like Himanshu was mentioning, it is a combination of the concentration as well as the molecular weight. Like you were saying, there's a sweet spot where there's a balance that is attained when the molecule does its best job. So it is not, if you keep on increasing the concentration, if you keep on increasing the molecular weight, you get the more molecular weight is better, or the greater strength is better. There is some combination. And like you said, when you're trying to combine it with some other molecule as a tear substitute, like maybe a CMC, the combination is also important. The molecules need to learn to work with each other. So there is some technology that they use to bridge these two together, and only then do you get the benefit. So it's not just the hyaluronic acid. There is a lot more that goes into it in terms of its final composition and concentration before you can get a drop that is useful for the surface. I think that's some of the from Peter Simmons' articles. I remember this particular issue.
Can we take more questions, Dr. Srinivas? Questions?
Yes, I think there's one question for you. Basically, the question was, in lime burns, how does a dry eye occur? What is the mechanism of dry eye in a
I
lime
think
burn?
it is very much similar to the way it occurs in SJS. So you have a limbal stem cell deficiency, which would lead to again conjunctivalization, disturbance of the ocular surface, vascularization, and would lead to the occurrence of the dry eye. So you have to treat the cause there. So if there's a limbal stem cell deficiency, you have to take care of that by surface procedures that we do, like clet or slit. And there again, studies have shown that the breakup time, the Schirmer, and all the other parameters do improve after the procedures, including the corneal clarity in some of the cases, most of the cases.
Nikhil, this is a question for you. Basically, the question was that we're seeing a lot of people was spending a lot of screen time, and then they come to you with dry eye symptoms. So, what would you suggest would be an ideal drop for such people?
Very
I
frankly,
think the question is because they probably do not. Yeah, sorry. You go ahead.
no. So I think
Go
basically,
ahead, Nikhil.
when we have patients on video terminals, or they are having computer related problems, my general principle has been that I give them maybe 2 or 3 lubricant options, and I normally advise them to use them, try one by one, and then whichever they're more comfortable, I would ask them to use them in their day-to-day problems. Because sometimes we may say that this molecule is superior to that, and that molecule is better than this. Patient's tolerance is something that we cannot predict based on only the science that we know. So sometimes I leave it to the patient, because some of these patients are not always happy dry eye patients. So give them 2 or 3 molecules by rotation, and then probably the ones which they're comfortable with, I would ask them to continue it, rather than forcing upon them that this is the best molecule for your particular sort of situation. That's how I do it, actually.
Professor Yokoi, there is a question about the use of oral rebamipide. Have you any experience with that?
No, oral rebamipide is not effective. Because
Not effective.
diluted 50 times.
Okay. Somebody had a question about the use of oral rebamipide. So I guess the answer to that is no.
We had a
Dr.
study
Rajesh,
there
I
at
think the
RP
question.
Center.
Yes.
I think
Yes, please
Rajesh
go
is
ahead.
already talking about. Rajesh, can you talk about the study, oral rebamipide?
Yeah, we had a study at RP Center, and we just wanted to know whether oral rebamipide is once taken, whether it's secreted in the tear film or not. And we could figure out that yes, there is a significant percentage that is there. So I guess that was the conclusion of the study. And whether oral rebamipide is effective in reducing dry eye symptoms, I guess that was not the research question, if I remember correctly.
Yeah. So those were the cases who were recruited from the GI clinic, because GI people are the ones who give oral rebapamide for gastritis. So they were recruited, and then their tear films were analyzed. The tear samples were analyzed just to see whether it gets secreted or not. So there is a question which I would like to ask both Professor Yokoi and Dr. Srinivas Rao and Himanshu, because he presented the T-FOS due to classification. Dr. Snehal wants to know that if we do any research studies, which this thing do we follow? The ADS classification or the T-FOS due to classification?
You mean for the
Depends on where you
definition
want
of
to
a
publish.
dry eye?
Yeah, for the studies, if we have to plan the studies, so what?
No, I think if he's asking about the definition of a dry eye, then it depends what instruments he has access to. Because according to the PFOS Deuce 2 classification, even to categorize it as a dry eye, he will have to have access to instruments that allow him to look at the tear homeostasis loss, like an osmolarity measurement and so on and so forth. And then after he's done that, according to their classification, if he wants to split them in the spectrum between evaporative and aqueous deficiency, he'll need lipid interferometry, tear meniscometry, and mammography. So if he has access to all this, then he would be able to define it. But if he's using Professor Yokoi's guidelines, all he needs is a blue filter on his slit lamp and a fluorescein strip. So that, and if he's adept at understanding the tear breakup pattern. So if he reads the book and he looks at the patterns, and if he's able to categorize the tear breakup patterns accurately, then he will be able to classify it as aqueous, evaporative, or mucin deficiency, or wettability dry eye. And then it also depends on what definitions he wants to use for his dry eye, I guess. So I don't think there's a single easy answer to that question.
Thank you.
Also, where does he want to publish the paper?
It depends whether it's Japanese Journal of Ophthalmology or it is, Cornea Journal from USA. So I think that will decide what do you want to do. There's
Right.
another question for everybody, that there are fluorescein strips which are available from so many companies. Do you think it makes a difference in terms of staining?
To the best of my knowledge, I don't think so, because the fluorescein is quite, it comes out of the strip very easily. So I think with the fluorescein, it's more the actual technique of use on the eye. My problem has been with the lissamine and the rose Bengal strips. So unless they're absolutely fresh, the ability of that dye to elute out of the strip, at least in my experience, has been very poor. And of the two, the rose Bengal is even harder than the lissamine green. So which is why when I use it, if at all I use it for conjunctiva, I've shifted almost completely to lissamine green. So the only time I really use rose Bengal now is when I have an ocular surface tumor where I still think there's relevance to it. I don't know about Himanshu. Have you noticed any
I
difference?
think you rightly nailed it, that for the fluorescent, it's the overstaining which is a problem. So most of the strips are actually good enough to give you the stain. In fact, we want less and less amount of stain for fluorescent than what we are getting. So I think it's absolutely fine whichever strip you are. And for rose Bengal, it's understaining which is a problem. So whichever thing you're using, I typically use 2 strips to rub and try to get as much as I get. So you have to find out whatever gives you maximum stain in rose Bengal and lissamine green, and anything is fine with fluorescent.
Another question, anybody can answer this. Choice of tear substitute in surface ablation, excimer laser, femto, and smile. Will it be different or will it be the same, Rajesh? What would you?
I guess the choice, I will go by what Dr. Nikhil told, that a lot of individuals have a different tolerance with different polymers. So whatever polymer you are using for your patients, you can use that. And if the patient is not comfortable with that polymer, you may change it. So, I mean, there's no one fixed polymer for a specific surgery or anything.
I think we need to do a study to compare the various polymers and say which is the best. And I don't think there are enough studies as of now. Dr. Srinivas Rao, there's a question for you. Which is the best tear substitute in dry eye with rheumatoid arthritis?
Again, since deficiency state most often, and they also have a lot of significant epithelial damage. I'm assuming they have the more advanced version of rheumatoid arthritis. I would, in my experience, use, if possible, an unpreserved drop and try and combine a CMC-based drop for the lubrication with some hyaluronate-based drop for the epithelial healing and regeneration. And of course, there will be significant inflammation on these eyes as well. So we can use some kind of anti-inflammatory, a cyclosporine-based system to try and counter that. And if you can get access to the diclofosol and the ribamycin, a working molecule, then that would help. All of this, of course, depends upon the grade of severity of the dry eye. You don't have to pour all of this in every rheumatoid arthritis patient who walks in, but I'm talking about a scale of 0 to 10, somebody between 7 to 10, then you may need to slowly add most of these options on those eyes as well.
I think one more point I can say is that when you have patients with very severe aqueous deficiency, these are situations, sometimes I tell my patients to put maybe more than a drop in the eye, let it flow out also, because it might increase the tear sort of clearance. And the other thing is that use a drop which is high viscosity as well as a drop with low viscosity alternately. Like sometimes we tend to feel that the eye is very dry, we give them gels and, you know, sometimes something like a very thick gel, which tends to crust and does not provide the tear clearance that we really require, in addition to sort of lubricating or, you know, moistening the surface. So I try to tell them to use a thin, low viscosity drop as well, which helps to wash off the surface of whatever, you know, debris or the inflammatory changes may be there. And of course, you can use a gel to coat the ocular surface as well. So maybe a little different than our normal dry eye patients, where you know, we probably don't follow these guidelines.
In that context, hyaluronate, in my understanding, is used about 4 to 5 times a day. Professor Yokoi, is there a guideline that you can give us as to the number of times you would use a hyaluronate drop? Because some of our patients like to use drops even every 15 minutes or every 20 minutes. With hyaluronate, is that advisable, or is that a certain minimum application that you would want them to stop with?
But it depends on the severity. In Japan, we prefer to using 6 times daily for the moderate case. For the mild case, 4 times daily is okay.
Okay.
Then you combine it with the Bell and Sol solution or saline, right? These cases.
Yes, sometimes.
And would you also combine, say, CMC with hyaluronic acid alternately or something like that? Like, do you use combinations or either separately or together in Japan?
We don't have CMC drop.
Oh, okay.
They don't have. So I think this is for you, Nikhil. In allergic conjunctivitis, which is what is the role of tear substitute? I think in
Yeah.
yesterday's webinar you already
Yeah.
clarified it, but yet again you need to clarify.
I think basically any tears, when we use tear substitutes in a patient who has allergy, one, it will help to sort of wash away any allergens which may be reaching the ocular surface, or wash away the inflammatory mediators on the ocular surface. Also, the other factors may be that we know that all patients who have severe or chronic allergy tend to have epithelial breakdown. So as I discussed today, it will help the epithelial regeneration or providing some sort of healing over the ocular surface. And it will also, most of these patients tend to have a dry eye because of the chronic ocular surface inflammation. There is surface damage. And so it will help to sort of keep the patient more comfortable. So, and this is something that we can give several times a day, especially if we have unpreserved drops, and it can help them to feel more comfortable. So I think lubricants play a very important role when we look at managing allergy, because the other agents, for example, you may talk of steroids or cyclosporin or the mast cell stabilizers, can only be used once, twice, or something like that. But if the patient is uncomfortable, probably this one you can use more frequently so that they're more comfortable.
So a lot of people are asking where will this webinar be available, because they want to, like go to especially the staining part of it and all the discussion. So it will be available. It is already there on the Facebook and on the AIOS YouTube channel. It will be available for everybody to, to go back to it if you want to refer back to it. And I think Dr. Nikhil has done an excellent job along with Dr. Srinivas Rao and the Cornea Society of India, where they have put it, I think, in their Cornea Society of India website also, and it comes as a newsletter also. All the staining patterns is available there. So I think everybody can watch it there. Are there any more questions, Dr. Srinivas? Or?
No, not that I know of. No, thank you.
Okay. So I think we will then call it a day. It was a very useful webinar. We already have more than 3,000 plus logins across all platforms, which is the landing page of AIOS, YouTube channel, and Facebook. And this will keep increasing as people would, watch it later. We would like to thank all the speakers, particularly Professor Yokoi.
Thank you very much.
Srinivas, would you want to say something? For
Yeah,
a
it's past midnight in Japan now, so it's
Thank
still
you.
not very late for a webinar.
Okay.
So thank you very much, Professor Yokoi.
But
We really
I enjoyed it very much.
Thank you.
Thank you very much.
So sorry for keeping you, keeping you so late in the night. You're still.
No, it's okay.
And it was very useful for all of us.
Thank you very much.
I'd like to thank Dr. Srinivas Rao particularly for steering the whole webinar. He's in fact the architect of this program and this webinar, and making it so very interactive, and all the questions taken, which doesn't happen in most webinars because they were classified so well by him, and all the relevant points which came out, all the speakers who were here. And would like to particularly thank Santon, Mr. Bhushan Nagpure and Mr. Gyan Prakash Saxena. Can we have your videos, please? And also the team which is back at the AIO's office, Mr. Kripal Rana and Mr. Sunil for coordinating it at the back office. So thank you so much, everybody. And if anybody wants to say anything, you're most welcome.
Good night.
Thank you. Thank you. Good night, everybody.
Thank you. Can't talk for dinner,
you.
but
Good night.
it was a physical meeting. Maybe it would have been followed by dinner as well. So thank you, Santon.
Bye-bye. It will be followed by